Hi, everybody. Welcome to our discussion tonight with our esteemed host, Glenn Grossman. I'm Rebecca Berman, thrilled to be moderating tonight's discussion. Cannot believe we are at the end of February 2021. We've been having these discussions for quite some time, Glenn, haven't we?
Yeah, it's been a while.
But we are grateful for that long while, and whatever the long while is to come. We really enjoy being together, both in person, and thank you everybody who is watching this on YouTube after our conversation. So, as many of us know and are familiar with, Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years, and he taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, the Military Health Service, the CDC, and other programs within the United States and abroad. All views expressed today are his own. So Glenn, how are things looking at the end of February 2021? Take us around the world and take us around the country, please.
Sure. Thanks for the introduction, Rebecca. Thanks everyone for joining us. Let me share my screen. All right, so let me actually start, in the United States. All right, so this is a graph that you all are familiar with at this point. The key, so over the last few weeks, you recall the numbers have been going down, both in cases, hospitalizations, and deaths. The big question has been variants. Would the variants start to level off this curve or potentially start to increase it again? And unfortunately, we are seeing that the decline that was happening so fast is now starting to level off. So we have this signal over here that it's just starting. So let's dig into this because it's kind of interesting. When you look regionally, so previously, let me go back for a second. Previously, when we looked at the national level, there were lots of jagged lines. Like, so for instance, after the second surge, you see all this weird stuff going on over here. So let me make it a little bit bigger, all this weird stuff. So is this just a weird thing going that's similar to the other weird things that we've had, or is this something really going on? And one way that we know that it's something really going on is that previously, after the second surge, you saw it in very specific states and very specific regions that this stuff was going on, whereas a lot of regions and states were unaffected. Whereas now it seems to be pretty universal across all regions and across most states. So let's go to the regions right now, because you can see it more clearly. All right, so for instance, in the Northeast, let me see if I can get there. So in the Northeast, you can see that it was going down and it started to level off. It's not really going back up yet, but has started to level off. In the Midwest, also it was going down, and you can see clearly that it started leveling off. In the West, it was also going down, and also it's still going down, but not as rapidly as it was before. In the South, you can see that rather than leveling off, it is starting to go up at a good clip. It's just been roughly a week or so, maybe a little bit more of a week of this, but it's enough of a signal that it's probably an early indicator of something. The fact that it's starting to rise like this means that's because this has been the big question. Over the next few weeks or months, will the United States have another surge because of these variants versus our vaccinations are increasing? So will the vaccinations prevent the surge? So what will the shape of this curve look like? And so now it's pretty much a race against time to get as many people vaccinated as we can before the surge and the variants start to rise. But the fact that we're seeing in the South some of these variants rising already are a little bit concerning. Let me pause sharing for 1 second. and just open up one more. All right, so what we're looking at here is the latest map of the variants in the United States. The three main variants that are being captured by this graph by the CDC is the UK, so the B117, which was previously called the UK variant, B1351, which was previously the South Africa variant, and P1, which is Brazil. The United States has had so many infections that we have our own variants in here. I'll talk about some a little bit later, but in California, there's a separate variant that people have been looking at that's similar to the South Africa variant in some ways. And in New York, they've also identified a new variant that's similar to South Africa and Brazil, but that arose independently. We'll look at that, but currently the CDC's website is only capturing these three global variants that people have been worried about. And you can see among these, the UK variant is spreading by far the quickest. Over 2,400 have already been reported, and it's doubling around every 10 days in the United States. The South Africa variant and the Brazil variant are spreading much more slowly, but what's unique about these two are that they have more resistance to the vaccines. So as more people get vaccinated, we might see an increase in these because they might thrive more in people and reinfecting people who have been vaccinated. But right now, we're very lucky that these are not very common because it means the risk to vaccinated people are quite low. The big states right now that have the UK variant are Florida is in the lead, then California. Oh no, Michigan just passed. Michigan, it was Florida and then California, but over the last week or two, it looks like Michigan has passed them. Michigan is rising very rapidly, and so that's interesting. But you can see that there is variation. This is the UK variant that we're looking at by state. So not all states are impacted the same way. New Jersey, for instance, only has 55 cases that have been identified. New York has 136, a neighboring state. So right now we're still not doing an amazing job of screening for these genetic variants enough. We're rapidly increasing our screening capability, our genetic screening capability, but we're still not anywhere near where we need to be. And so this is still something that we're ramping up. But already, and so it makes it hard to compare this week versus the week before versus the week before in terms of the reported cases, because we're sampling more, and so that means we're more likely to find cases. So we don't know if a new case, if we're seeing more cases simply because we're screening more, or whether it's because it's spreading more in the United States. We can do that based on working backwards, based on the reported sampling rate, the screening rate, but I haven't seen it put together in a good website yet, and I haven't done the exercise myself. So anyway, here's a decent snapshot of where things are right now. Let me go back. So in terms of regional cases, like I said, the South, we're seeing what I guess you can say is the beginning, is very likely to be the beginning of a surge of some kind or another. I don't know how big it's going to get or what, but we've had sort of these false things in the South before, but it looks like this is something that a lot of us are going to be paying attention to. The fact that this is leveling off elsewhere in the country means that it's also at risk that we can also start to see an increase in some other places as well. So the next probably 3 to 4 weeks, up to a month or two, is really going to be a time when a lot of us are going to be paying close attention to these early signals to see if the variants are going to start rising. Globally, all right, so globally, let's just take a look. Interestingly, so we can start with Brazil. Brazil, it's summertime there right now. So they're in South America. It's summer in Brazil. And so this is a seasonal virus. We've seen across almost every other country that there's a huge seasonality to it. And so the fact that it's still burning hugely in Brazil is very disconcerting, because what's going on there is that there were previous outbreaks and previous surges that were going on. In fact, some cities reached what they thought was herd immunity, where over 75% of people were infected, but the new variant emerged in Brazil and people started getting reinfected. And that is still burning through the country right now. And so it means that in Brazil, there was no sense of this idea of herd immunity does not exist, because if it existed, they would have hit it months ago already. And the fact that it's still so high going through the country is very disconcerting. The United States, we've been dropping a lot, what I just showed you, but now it seems to be leveling off some. South America in general, largely because of Brazil, but not only because of Brazil, it still has a lot of cases that are being generated. Europe, some countries are driving this more than others, but there are still a lot of cases in Europe that are going on. United Kingdom had this peak because the UK variant, based on some studies, the UK variant was estimated to be 50% to 70% more contagious than the previous variants. So this is very disconcerting. The reason that the curve is starting to come down is because of their shutdowns that they had that had a massive impact on reducing the spread. But without the shutdowns, they would have been in trouble. And so now the UK variant, again, this is what I was talking about over here, this B117, that there's so many cases, that's the UK variant. So it's not enough that we're seeing a massive spike like the UK actually saw, but it is something that a lot of us are worried about because we want to make sure we don't get a new spike like that. Canada, I put in there. I know some of our viewers like to see what's going on in Canada. South Africa, also the South Africa variant. The South Africa variant doesn't seem to spread or be as contagious as the UK variant, but what's unique about the South Africa variant is it has higher resistance to the vaccines, and that's why a lot of us are paying attention to it. And not just the vaccines, it also means higher resistance for people who are previously infected. So similar to Brazil, if people were previously infected, not only do they lose the protection over time, but in addition to that, these new variants that are emerging make it increasingly likely that people can get reinfected. Asia remains generally pretty good. India is pretty good right now, and Australia has remained generally pretty good. So this is at a high level in terms of the epidemic. We're going in a good direction, but a lot of people are paying close attention to the vaccine rollout and to the variant emergence. Now, when it comes to the vaccine rollout, let me go down to the first. Give me 1 second. Not interested in that. Not interested in that. I want to see what percentage of the population has received at least one dose of the vaccine. So Israel, again, in the lead, over 54% of the population have gotten the first dose of the mRNA vaccine, so that's great. Over half the population has gotten at least one dose. In United Arab Emirates, it's over a third. United Kingdom, almost 30% have gotten at least one dose. United States is around 14.5%. We're increasing rapidly now, in large part because of the new emergency use authorization that was just granted for the J&J vaccine yesterday that we'll talk about in a little while. But so we're rapidly so between that and the increased number of doses that we've gotten from Moderna and Pfizer, they're ramping it up. So we should see a large spike in vaccinations in the coming weeks in the United States. When you look at the growth over time, you can see Israel, not only it got high so fast because the growth rate was so high, it was the ramp up curve was so strong. The United States, where are we? We're over here. Our ramp up curve is still not as great as we would like. It's been on a very similar curve to where we were back in January, early January. But now with the new emergency use authorization and the new deals between Moderna and Pfizer in the United States, the United States purchased, I think, around 100 million more doses after Biden came into office. So we should see that reflected in the curve within the coming weeks. The other question now, so this is people who have received at least one dose. Now the question is among people who have been fully vaccinated. And so among fully vaccinated, Israel, so 38% have been fully vaccinated at this point. This is 38% of the entire country. Because they heavily vaccinated the people over the age of 65 and the high-risk people first, then those people have much, much higher percentages. We can get into that in a little while as well. And so yeah, in the United States, it's currently around 7% of people have been fully vaccinated at this point. And again, in the United States, it's the healthcare professionals and the high-risk people that have been prioritized first. So the percentages are much higher among those populations. All right, let's see. So this is what we're talking about with the vaccines. Let's take a global look. So on the global level, whoops. So you can see that there's much of the world that's getting vaccinated. The rates vary a lot, but you can also see that there are a bunch of countries that are not really vaccinating at all, and some are not vaccinating very fast. And so this is going to become a worry in the next months and years, because countries that don't vaccinate will likely, they're going to have continued spread over time. And that means that there are going to be places where variants might emerge that are new and might be able to break through some of the vaccines. So in terms of when we look at evolution, evolution is really going to be constrained for the variants, because if there are not a lot of copies of the virus that are produced in areas that are highly vaccinated, then that means there's not a real big opportunity for evolution to occur. But in places where vaccination is slow and there's lots of copies of the virus that are made, then it makes it much easier for variants to emerge that can break through the current vaccine shield that we've developed in a lot of our countries. That's why it's so important. That was one of the first things that Biden came in when he came into office. One of the first things he did was he had the United States donate billions of dollars to the international program sponsored by the World Health Organization to vaccinate the rest of the world that can't afford the vaccines. So for two reasons. One, the ethics of simply, we're a global world and we need to help humans in general, but then also helping other people in other countries will come back and help us, because it will prevent these variants from coming back and breaking through our vaccine shield. And so that's it. This is where we are so far. I think that's it for now. Everything looks great. Other than the new variant that I just mentioned, we still have a much lower number of cases, hospitalizations, and deaths that we had since the peak. And so that's great. We're still not out of the woods. Like, so for instance, when you look at cases in the South, the number of cases that we have is not much smaller than the number that they had at the peak of the second surge. So we're still not out of the woods in any way. When you look at the total number of deaths in terms of the severity of this illness that's still striking the United States, this is still a massive disease. So when you think back to the shutdowns in March and April, the number of people that were dying back then is roughly the same to the number of people that are currently dying each week. So we're not out of the woods. Things are going in a much better direction, but we're not out of the woods. This virus is impacting a lot of people right now still. And so everyone still has to keep their masks on, socially distance, get vaccinated as soon as they can, and do all the other things we've talked about. And we can dig into some of these in a little while with the questions. All right, Rebecca, let me.
Okay, great, terrific. Glenn, thank you so much for sharing with us what's happening around the world and taking a deeper dive into what's happening right here back at home. So we have a question from Rachel Scherzer. If you could please unmute Rachel regarding herd immunity.
Hi, everyone. Thanks, Glenn. This is really interesting as always. Question for you. Is there a difference between herd immunity from a vaccination program versus herd immunity from just infection? So I know you were saying that in Brazil, we have, it's a strong indication that herd immunity is not possible through this virus as a result of this virus. Is it possible with vaccinations? Is there a difference?
That's a really good question. So the idea of herd immunity originally came from herds, from actual cattle and herds out there, where they found that when an epidemic would rush through natural herds, that not every member would necessarily die in that herd. And that was where this idea of herd immunity came from. And then what we found is with vaccinations, you could eliminate a virus from the population and protect the people who were not vaccinated because of this sort of this halo effect, where people had enough protection in the population so that people who are not vaccinated would then not have to worry as much. And we do see this in measles. With other viruses like smallpox and polio, we're able to eliminate them because of this idea of herd immunity, where you vaccinated enough people that it just died out of the population and couldn't reproduce. But the big issue with the spread of the virus, because it's happened so fast, and the vaccines, as fast as they were not fast enough. As a result, we have an enormous number of mutations, of variants that have formed around the world. And so now some of the variants are more or less resistant to the vaccines at different levels. And the worry is that those are just the ones that we know of. Now, as vaccinations become more common, the variants are still mutating out there. And so we could have additional variants that arise, almost certainly we will, and some of them might be completely resistant or much more resistant to the vaccine. And so that is the worry. If you want, let me open, this is the discussion for the question of herd immunity. So let me dig into this a little bit. So previously, when we were talking about this idea of herd immunity, now, so let me also remind you of one other thing. The vaccines do two things. One of the things the vaccines do is it protects from serious disease. It prevents serious symptoms. And that's great, because ultimately, once we no longer have severe symptoms, then the disease is over. Who cares if you just get a common cold at that point? Because we get common colds all the time. Who cares? So that's great. That's the key. That was the major reason that we got the vaccines out. That's what all the studies were designed to look at. They were simply designed to look at reduction in severe symptoms, hospitalizations, these other things, death, etc. But the vaccines are also, we're looking for herd immunity. And that is a different question, because that is whether people, once they're vaccinated, can still get infected and then be contagious to other people. And so these are two different questions. The transmission question hasn't been studied very well because it was outside of scope of the clinical trials. So let's talk a little bit more about the herd immunity threshold. Originally, there are two things that we were looking at with how quickly the virus spreads. You'll remember this concept of R, and this was the reproductive value, how much it reproduces. If you had an R naught, so this was when there were no masks, when people were not physically distancing, when there was no precautions taken at all, how much did the virus naturally spread? In the United States, on average, our best estimates were that the virus spread, the reproduction rate, was roughly 2 to 3 in the United States. However, it varied dramatically. And in New York, it was as much as 5.3. In New York City, it might have been even higher than that. And the reason is that the things that determine how contagious a virus are not just the virus itself. So we see that there's different variants that are spreading at different rates. So one reason that the virus spreads or is more or less contagious are based on the virus attributes. But that's not the only thing. There's two other things. One other thing are patient characteristics. So for instance, some people might be more or less likely to spread the disease. So for instance, you heard, we haven't talked about it in a bunch of months, but the idea of super spreaders, where one person might infect many other people, and that is a patient characteristic rather than specifically a virus. So for instance, maybe some people talk louder, and that might contribute to more spread. Or maybe some people, when they're infected, their symptom is coughing more than other people, and maybe the act of coughing is more likely to spread the virus. So there are attributes about the patient that might make them more or less likely to spread. And if there are a larger concentration of those people in one area or another, then you're going to have more spread. The third thing are social and cultural norms. So for instance, in some places, it might be more common for people to stand closer together than in other places, or to live with more people packed into a small apartment. For instance, in New York City, where the apartments are so expensive, you might have 4 or 5 people living in very small apartments to save money. Whereas in the South, maybe Alabama, you could be living over a much bigger area. And so, because it's a lot cheaper to buy a house there or to rent a house there. And so as a result, those things have a big impact in terms of how much the virus spreads. These 3 things: virus attributes, individual patient characteristics, and then social or cultural things that are going on. The other thing is, so for instance, in New York City, not only do you have to worry about the apartments being small, but also if you go on the subway system there, if one person gets sick and you have a really, really packed subway, then you could infect theoretically the whole car of passengers. Whereas in Alabama, if there's no packed subway that exists, then it's just impossible to infect so many people at once in that situation. You can do it in other things, for instance, maybe in indoor sporting arenas or things like that, but it makes it harder to spread to so many people. So as a result, these things are really contributing to how much spread is going on. All right, let me, that was the question of herd immunity. Let me open it back up to you, Rebecca. Unless, did I answer that sufficiently, or, okay.
Excellent. Thank you, Glenn, for taking us through that. Thank you, Rachel. Great question. Okay, so
Rebecca, do you want me to jump into transmission since then? I know that was a different question. Or you want me to just continue talking, or come back?
Jump into transmission. Absolutely.
All right, so we have limited data on transmission, but we do have some. And so the 2 big sources of transmission data right now are UK and Israel. In UK, what they did is they found, well, there's 2 questions about transmission. So first, the question is, among people who get vaccinated, what percent of them can still be infected? And that's an easier question to figure out, because all you have to do is vaccinate people and then test them, do PCR tests and see how many people get infected. It's a much more difficult question to see how many people are infected from someone who was vaccinated and then infected. So this idea of transmission, because for instance, if someone is vaccinated and then infected, they might have a lower viral load, which means even if they are infected, they might be less contagious than someone else who would have been infected without the vaccine. And so this is unknown. Right now, we know the infection rates, but we don't know how contagious they are, particularly people who are vaccinated and asymptomatic. But let me jump into this because there's a bunch of interesting ideas that have come about here. So in terms of the first question, in terms of how likely is it for people who are vaccinated to get infected? So in UK, where remember the UK variant is very common, what they found is that people who were vaccinated in UK, it reduced infection by 67%. So it still reduced symptoms much more than this. It's still the key thing that a lot of us were worried about is symptoms, keeping people out of the hospital, keeping people alive, making sure we don't get severe symptoms. It works great for the UK variant, so we don't have to worry about that so much. But the question for whether it is equally preventive at reducing the risk of getting infected, it seems like a lot of people in UK are getting infected. It reduces it by 67%, which is huge. In contrast, in Israel, it reduces it by, I think the key takeaway here, in asymptomatic cases, it reduces it by 89%, and in symptomatic cases, it reduces them by 94%, essentially. And so this is huge. So it's around 10%. When you add up all the asymptomatic and symptomatic cases, it reduces the total number of infections by 90%. So you'll end up with only 10% of what you would have. So this is great news. And so let's dig into this a little bit more. The key question here, let me see if I can find this. are these immunoglobulins. So there's different types of antibodies that are produced. I like this graph, so let me make this a little bit, or this picture, so I'll make it a little bit bigger. The worry is that that when you create antibodies, there's two different types of antibodies. There's actually more types. There's a bunch of different types. But the two primary types that are interesting for this discussion are immunoglobulin G, which is what prevents the systemic effect, so prevents the symptoms. And then there's immunoglobulin A, which are located more in the in the upper nasal area, the upper respiratory area. And so these are generally very different immunoglobulins. What we found is that the vaccines are really good. A systemic vaccine that you inject in your arm, they're generally, not just for COVID, but in general, tend to produce immunoglobulin G a lot. That's why it prevents the systemic effects, but they tend to be very poor at creating immunoglobulin A. And this is one of the reasons why people can still get infected in their nose. They can still spread the disease, but they're protected from severe symptoms. So even though they might get infected up here and still spread it to other people, they're not going to have the severe symptoms that they would have otherwise had. So the question is, there is a study that was just released in the last week or so, no, January 30th. So this was around a month ago. And this was looking specifically at the different immunoglobulins. So let me look at this just because it's kind of interesting. So immunoglobulin G, that was the first one that we just talked about, the one that prevents the severe symptoms. So right now you can see there's three things here. There is the control. So this is people with no vaccine. mRNA 1273 is the Moderna vaccine, and BNT 1262b2 is the Pfizer vaccine. And you can see when it comes to immunoglobulin G that the Moderna vaccine and the Pfizer vaccine are essentially the same. They look identical when it comes to how much immunoglobulin G they form in terms of how much protection there is. So when it comes to severe symptoms, both in the spike antibody as well as in the receptor binding domain antibody, you see that there's an enormous difference versus control, and the Moderna and the Pfizer are about equal, which is great news. Immunoglobulin M is another one. I'm not going to pay too much attention to that because for this discussion, immunoglobulin A is the one. Now, immunoglobulin A, you see that there is a little bit of a difference between the control. You can see the shape of the curve looks dramatically different than immunoglobulin G. This is really different curves versus control. For immunoglobulin A, you see that there is a difference in the height of some of these, but you see that it doesn't have the same type of shape that was really pronounced in terms of the immunoglobulin G. And so it means that this is the reason, this is just clinically what's going on in the body that's consistent with the reason that people can still be infected. It's because of this, that the immunoglobulin A's are not as strong. Interestingly, the gray here is mRNA 1273. This is the Moderna vaccine. And so it seems like, just looking visually, the Moderna vaccine might be slightly better at preventing infection, but it's still not exactly clear. One thing we do know is that the Moderna vaccine actually has a much larger volume of mRNA that's used, because early on we weren't quite sure exactly what dose would be best. So Moderna's strategy was actually to increase the dose. So the same 2 doses, so we have 2 dose regimens, but within each dose, Moderna's has been a higher volume within each dose. And that might be one reason why it's spreading a little bit more for the or giving more protection for immunoglobulin A, both for the spike protein as well as the receptor binding domain. We don't know a lot of things. For instance, the persistence, how long is the protection going to be for each of these vaccines over time? Will we need booster shots? We don't know things like this yet. But when you look at a high level at the total, so these are controls versus vaccinated and immunoglobulin G, you see that there's a big difference between the average for immunoglobulin G versus the control versus when you look at immunoglobulin A, it's a much smaller amount. And so that means this is why people can get infected. So now that we've seen that, so now you understand the underlying, so if you read these things in the news, now you hopefully have a better understanding of some of the underlying concepts. Let's talk about what this means in reality and in practice, because a big question that people have had consistently, this is probably the biggest question that everyone's been asking me over the last few weeks, is now that they've been vaccinated, when can they stop wearing masks? When can they stop physically distancing? And when can they get back to normal after they've been vaccinated? So let me answer that question now. So based on what we've just discussed, let's talk about this. So first I'll go back to this idea of herd immunity. So the idea of herd immunity really is a question of, oh, where did I just put that slide? Well, let me just talk about it. The idea of herd immunity, the main reason that it's even a thing is because of this halo effect. We know that not everyone can get vaccinated. And so the question is, so for instance, people with cancer, and so people who are immunocompromised or might have contraindications or might have allergies to the vaccines themselves, they can't get vaccinated. Kids can't get vaccinated. So the question, yet there's clinical trials that are going on for kids, but currently there are people who simply can't get vaccinated. And so the goal of herd immunity is that you have this halo effect where people, if enough people get vaccinated, then they can protect the ones around them who can't get vaccinated. And so the question is, is vaccination enough? So let me jump into this and show you some of the back of the envelope calculations that I did. All right, so let me walk you through. There's a lot of numbers on this slide. NPI is non-pharmaceutical interventions. So NPI includes everything like mask wearing, physically distancing, staying outdoors where we can, ventilating, all the things we've talked about. Those are typically NPI. So everything that's not a vaccine and that's not a treatment. In New York, back in March, the estimated R, the reproductive value of the R naught, when there was no anything, no one was doing any precautions at all, it was estimating that on average, one person infected 5.25 other people on average, which was the highest in the country. In New York City was definitely the highest in the country. On average, the US was around an R of 2 to 3. What this means, the first insight here, is that it's going to vary state by state. Because if a state like New York, or in particular the city like New York City, has a really high R, then that means that even after vaccination, the thresholds might be higher that they need to hit versus a rural state where the R value was much lower. Because if you recall, the magic number here for R is 1. When R is below 1, whether through vaccination, through the NPIs, or through whatever reason, once R is below 1, the reproductive value is below 1, then the virus will always die out on its own in the population. Because on average, each person who's infected will infect less than one other person. The smaller the R, the more rapidly it dies out. But the R of 1 is the magic number here that we're all looking for. So the question is, what do we need to do to get R lower than 1? On average, what we estimated globally is because people weren't wearing masks 100%, because the ones who were wearing masks typically didn't have a very good seal, and the masks weren't as effective as we had hoped. What this means is that on average, in the real world, if you were together in a living room with other friends, just someone's house in the living room, the masks typically only reduced spread by maybe 20%, 25%. So that means in New York City, if you had an initial R, this R naught of 5.25, and every single person wore masks, you would still only reduce the spread to 4.2, which would still be an epidemic. It wouldn't be enough. Within a living room setting, assuming that this was that a lot of people were still hanging out in living rooms together and whatnot. However, if you reduce the time together, so instead of being together in the same room for 4 hours, you reduced it to 2 hours or less, and you increased ventilation, you opened the windows, opened the doors, had heavy ventilation, then, and everyone wore masks in addition to that, then you reduced it below 1. And so because of that, it would die out on its own. If it was universal, that universally everyone that got together was wearing masks, reducing time together, ventilating, etc. All right, Rebecca, just give me a minute. Let me just get through these 2 slides and we'll go. Now, if 100% of people get vaccinated in that same situation, under UK, remember, we said under UK, it reduced transmission by 70%. And in Israel, it reduced transmission by 90%, or in that case, not transmission, reduced infection. If we assume that infection is transmission for the sake of this argument, then these are the numbers that we're looking at. That means that under the UK assumption, in New York City, vaccination alone would not get it below 1. And this is a major, major point. So under the variants of concern that are starting to spread, in New York City, it would not get it below 1 based on how rapidly it's spreading. In Israel, it would, even under, because it reduced it by 90%, under the current variants that are common in the United States, because UK variant is not the most common in the United States yet, it would reduce it far below 1, and so it would die out on its own. The question is, how quickly will the UK variant spread and these other variants? Because if we can't get it below 1, then the only way to get it down, to stop the epidemic, is going to be that people are going to still need to be wearing masks on top of vaccination in New York City for a while. Let me show you a couple of other slides though. All right, the next question is, all right, the UK variant, so this is the rub. The UK variant is more contagious than the current variant. So previously in New York City, or New York State rather, it was 5.25 on average, but now the UK variant, if it's 50% to 70% more contagious than what's been common in New York, then instead of 5.25, it means that it goes up to 8.9 or 7.9. Then if you wear masks and stay in the living room, you only drop it to 6.4, which is huge. If we do everything we've been talking about, but people still congregate indoors, which means we don't have a shutdown, but people still wear masks, they reduce time together, they heavily ventilate, then you still have an NPI, then you still have an R above 1. So again, the previous one, you would have had an R below 1, the epidemic would have stopped. Under this situation where the UK variant is spreading, you have an R above 1. That's why UK needed to shut down, because it was rising so rapidly, even with the masks, even with ventilation and everything. Now, if you get a vaccine with the UK variant and you do not wear masks and this other stuff, under the UK assumption of how much it reduces spread, it drops from 8.9 to 2.7. And 2.7 is still a large spread, so you will not stop it without masks. However, if it reduces as much as it did in Israel, 90% reduction, then you do fall below 1 even without masks. But you're right on the edge. So now this is New York City. I was literally picking out the worst example, but it's a real example. So people in New York need to be aware of this. But in much of the rest of the country, the R was not 5, the R was 2 to 3. The US average was 2 to 3, which means that some are above 3, like New York and New Jersey, and some are below 2, like in some of the more rural states. So if we use an assumption of 2.5, so the midpoint between 2 and 3, then that means if we have the UK variant that's spreading within the next month or two, and it's 50 to 70% more contagious, then that puts you at 4.25 to 3.75. Let's just call it 4. If you reduce that level by wearing masks, that only brings you to 3.2. But if you wear masks, you heavily ventilate and whatnot, then for much of the United States, you will fall below 1. So that's good news. Among people who get vaccinated, you'll fall from the 4 down to 1.28 if it's the UK estimate in terms of how likely it's going to reduce transmission. and down to 0.3. So it's going to be very effective. So when it comes to the question of can we stop wearing masks, we don't have the definitive answer yet. And this is why. But given what I've just described to you, we know that in New York, the R naught was higher, which means it's the threshold, even though the threshold of 1 is the same threshold everywhere, it's a further distance that we need to go in New York, and particularly New York City, than in many of the other states in the country. And so ultimately, people are going to be asking for one answer. In the United States, people are going to just say, I've been vaccinated. Do I still have to wear the mask? And the problem is the answer is going to vary based on all the things I've described. The variants that are more common in the state are going to make a difference. The R naught, the initial R, is going to make a difference, etc. So these are things that we're going to be needing to think about as the CDC and other public health officials make recommendations on when we can stop wearing masks after vaccination. A lot of information.
That was amazing. I have to say, I'm so impressed by your back of the envelope ideas compared to my doodles. This is really very impressive. So glad we're sharing your back of the envelopes versus mine. So thank you for taking us through why the answer is somewhat murky and how masks will be with us for quite some time. Very helpful. Okay, so a great question came in from the audience about whether or not employers have the right to require vaccination.
That is a really good question. And let me see if I can answer that. All right, so a lot of words here. So there have been a lot of opinions that I've read looking at do employers have a right to enforce their employees to get the drug? First of all, or the vaccine in this case. First of all, currently the vaccines are not technically approved. They're all being released so far under emergency use authorizations. And an emergency use authorization is sort of this preliminary release where you allow people to take the drug or take the vaccine because of the emergency situation, but the threshold is not the same as required for approval. And the reason is there's always safety and efficacy thresholds. It doesn't mean that the vaccines are not hitting the safety and efficacy threshold. What it means is that it hasn't been evaluated for those thresholds yet, because our goal was to get it, given the amount of risk in the population. Everything is based on the amount of risk that we have. That's why the emergency use authorizations were given. Currently, as of December 16th, the Equal Employment Opportunity Commission, so this is federal organization, federal government, the executive branch, said that employers do have the right to require vaccinations. For previous vaccines, it's been upheld and settled law that employers did have the right to force their employees to get vaccinated. This doesn't mean that the employees are required to work for the employer. An employee who refuses vaccination, if an employer requires it, can just simply decide that they don't want to get vaccinated, and then that's fine. But there's two interesting things here, and there's some competing ideas in terms of what is likely to happen based on this. First of all, this is very likely to go to the Supreme Court because it's an emergency use authorization. It's not an approved vaccine, and so it's technically a new idea. And so it's going to go to the Supreme Court most certainly if employers start requiring it. I have no idea how the Supreme Court's going to rule, and I don't know that anyone can accurately predict what's going to happen now with the new Supreme Court based on the new appointees. Having said that, for all intents and purposes, the emergency use authorizations should be interpreted as if they have been approved based on the safety and efficacy that have been demonstrated by the clinical trials. So everyone in public health is assuming that the emergency use authorizations are as if they have been approved. So that shouldn't be an issue, but it will probably be evaluated in the coming months. Almost certainly the vaccines will move from being emergency use authorizations to being technically approved, which would make a court case moot if it was based simply on the emergency use authorization. Another thing to think about is that all of the tests, the PCR test, the antibody test, all of the COVID tests that we've been getting over the last year, all of them have not technically been approved either. They have all been approved under, or rather given the designation under emergency use authorizations. And employers currently are requiring all of their employees to get tested. And if they can require their employees to get tested under the emergency use authorizations because the tests aren't approved, then why should we allow them to have this criteria for the tests, but not for the vaccine? And so that's an interesting argument that the courts might take up. The other question might be, well, maybe there's a middle ground. Maybe they require vaccination for everyone, but people who refuse to get vaccinated could have this middle ground where they'd be required to layer on extra personal protective equipment. And so maybe under that scenario, that would pass legal muster and that would be okay. But this is where we are. It's going to be evaluated by the courts, so who knows what's going to happen. But these are the major issues that are being evaluated, and this is where the federal government currently stands based on with the report that they put out of the Equal Employment Opportunity Commission, the EEOC. So for most other vaccines, employers are allowed to require it. The employees are not required to continue working at a company where they don't want to be vaccinated if they don't want, and then they can leave if they want. So that's where we are.
Very interesting. So on the same lines of this discussion about emergency use authorization, lots of questions about the J&J vaccine that has received emergency use authorization. So now we have three. We've gone through the details looking at Moderna and Pfizer. Could you tell us, please, about Johnson & Johnson?
Yeah, so this is an interesting question. People have asked me, what vaccine should they get? And always the answer is get whatever vaccine you can get, because it's so hard to get an appointment. They're all roughly the same in efficacy and safety, even with the new data. And the reason is you might see different numbers. We've talked about the numbers before. Let me see if I can pull up the chart real quickly. So these were the early estimates that we were getting. Pfizer, Moderna, and now we have J&J. Efficacy for the old variants were 95% and 94%, so roughly the same for Moderna and Pfizer. However, they appeared less for J&J. But I keep telling people, the problem is with the J&J vaccine, it's not what we might call a head-to-head trial. We can't really compare these two clinical trials or these three sets of clinical trials because the J&J vaccine, by the time the trials were started, they were given to patients in South Africa and United Kingdom and other places where there were these new variants. So Pfizer and Moderna, these were all tested before these new variants emerged. If they had to redo the clinical trials now, their numbers would be also much lower and would probably be very similar, if not identical, to what J&J's results were. So just because the numbers reported are different doesn't mean the vaccine's any worse. It's because it's just a constraint in terms of how the clinical trial was conducted based on the new variants being out there now. The one-dose vaccine for Johnson & Johnson is great news. You don't need 2 doses. And so that's going to be a real big help for a lot of people to ensure that we get people vaccinated. The other thing, some key things that people might be interested in. So it prevents it's demonstrated to be 85% effective in preventing severe or critical COVID after around 28 days. So after around a month. So when you compare around a month and 2 weeks for the Moderna and Pfizer to a month a month here with the J&J, the numbers we're looking at again are 85% to the 95% or so. Again, you can't really compare it very well, but 85% is amazing. It's really darn good. And so that's the key thing that we're looking at here. One interesting thing, so I was looking at variation. So this is the report. This is what the FDA was looking at This was their briefing document when they were evaluating the efficacy and safety of the J&J vaccine in the last few days. One thing that's interesting that I still don't have a good answer about. So the mRNA vaccines, those are based on RNA. We've talked about that before. What's new about the J&J vaccine is this is based on the adenovirus. So it's actually what they do is they take the spike protein from the coronavirus, and then they insert it into this completely different virus that's harmless, the adenovirus. And the adenovirus then sprouts all of these spike proteins on its surface. So it looks like the coronavirus, but it can't infect a cell like the coronavirus would. And that's what stimulates the immune system. The problem is, and this is still something I'm trying to figure out, and I haven't been able to find a good answer yet, which makes me a little bit, it's still on my radar. I haven't been able to remove it from my radar yet, is that there have been HIV vaccine trials, and they found that some of the HIV vaccine trials that themselves used the adenovirus, where they had the HIV spike proteins, they weren't actually spike proteins, but the surface proteins, they had the HIV surface proteins on the adenovirus. They found that people who were vaccinated with that HIV vaccine with the adenovirus were more likely to get HIV. So vaccines you think of as being protective, this actually made people more likely to get HIV if they got the HIV vaccine. And there were a bunch of possible reasons why this was the case. That vaccine was immediately thrown out. They're no longer evaluated, but it was a caveat now. And so one of the suspicions was that the adenovirus itself made people more likely, if they were susceptible to HIV, it might have made them more likely to get infected with HIV, that there might have been something about the adenovirus. And this is still an open question. I don't know how valid it is, but for people at high risk of getting HIV, for instance, African Americans in the United States, Africans in general who on the continent, gays who are at higher risk of HIV, this might be something that we need to worry about. So for instance, can you imagine if African Americans already have severe vaccine hesitancy? They also, African Americans in the United States, tend to be at higher risk for contracting HIV for a variety of reasons. Can you imagine if we finally get over vaccine hesitancy for African Americans and we say, look, it's only one dose, just take this one dose of this J&J vaccine, but we find out months later that it actually increases their risk of getting infected with HIV. This would be terrible, and we don't have a good answer yet. I don't know how likely this scenario is, but it worries me that I don't have a definitive answer. It's not something that you can easily evaluate epidemiologically with the way that the studies have currently been constructed. And so as a result, there's no firm answer that can conclusively say it's not the case yet. So that's why we're still evaluating it. One interesting thing is that the studies have not been reporting out a lot about HIV infection, but J&J did. The numbers are really, really small. And one curious thing about the J&J vaccine, we can't really interpret it very well because the numbers are really too small to really interpret it. HIV is an immunodeficiency disease. It gives people, it compromises their immune system. So a lot of times vaccines don't work very well for other diseases in general. But curiously, what they found, just based on the few, there were enough that they reported it, is that what they found is that there was no protection within 2 weeks for people with HIV. So again, this is the J&J vaccine. These numbers are so small, you can't really interpret it, but there was not strong evidence. You can see for other populations, it was around 60 to 65% protective. Among asthma patients, 87% protective within 2 weeks, starting in 2 weeks. But with HIV, they did not find this protection, which is curious. At a month, they found that there was some protection, but it was not nearly as protective as they found for a lot of these other populations. Curiously, one signal they found were people over the age of 60 who had comorbidities also seemed, for some reason, not to have the same level of protection as some of these other people. still something that we don't know, that we're still trying to figure out. Is it something to do with the variants? Is it something to do with something else? We're not quite sure yet, but this is something with J&J. Ultimately, everyone over the age of 65, or over the age of 60 soon, but particularly over the age of 65, should be getting the vaccine as rapidly as they can. With the and the vaccines already on the market now are the Moderna and the Pfizer mRNA vaccines. The J&J vaccine will probably become available this coming week, which means people over the age of 65, if I were them, I would say, okay, maybe still go for the mRNA vaccines. But there's no excuse now. People over the age of 65, go out and get the vaccine now. You are eligible. Now they're starting to open it up for a much wider group of people around the country. And it's going to get harder and harder for these high-risk groups to get vaccinated going forward, because it's as hard as it's been. Now that they're opening it up to more and more people to be eligible, it's going to get hard to get a vaccine. So people over the age of 65, or who are currently eligible because you're high risk or a healthcare professional, please don't hesitate. Go and get back your schedule to get vaccinated as quickly as you can. Okay, that was a lot of talking.
Mm-hmm. No, that's an important public service announcement. So we do appreciate you sharing this in-depth analysis. And just the bottom line is, if you're able to get the vaccine, if you're in one of those groups, to go and get it, because like you said, the eligibility requirements are going to become more and more, they're going to be loosened, and the vaccines will become more and more available to wider populations, and then perhaps less likely available to the original population. Okay, so we are at the top of the hour, but I'd like us to wrap up with one more question. We've spoken a bunch about the UK variant, the South African variant, the R2D2 variant. No, I'm only kidding. I just named it that from all of your codes you shared with us. And now we have a New York variant. I mean, can't we leave the New Yorkers alone? Keeps coming back to New York. What is going on with this New York variant?
So yeah, there's one that's been identified. The number of variants, they're still proliferating. There's a lot new variants that are still forming as we speak. These are the ones that have been identified. The one in New York, I think that there's two. They're sort of being combined under one name now. One was B1526. I think it was like B1525. I forget the exact other name, but they're sort of being combined into one because they share very similar characteristics. They're very similar to the South Africa and Brazil variant. So what does that mean? It means that the vaccine will be less effective for them. The vaccines will still be effective. They have not broken through the shield. The vaccines still do protect, but what it means is that it's not as protective as it's been for the other ones. So it means that maybe if someone is vaccinated and they get infected with the New York City variant, the South Africa variant, or the Brazil variant, what it means is maybe they'll get severe symptoms to a higher extent than they would have otherwise, but it will still prevent them from being hospitalized or from dying. So the vaccine is still protective, but these are starting to sort of really push the limits of how far the vaccine can go. The worry is that if these variants continue to evolve because of the same idea of antibiotic resistance, if they continue to evolve from the vaccine resistance, then you might have new mutations and new variants that arise that can break through and spread among vaccinated people as if they were not vaccinated. So right now, this is still something we're watching. We don't have a lot of good data on it. There have been a couple early studies that have started looking at it, but right now there's not a lot of information that we can really look at. They do have, but like I said, they do have some of the main mutations that have been under concern that we've been looking at globally. So it's here, we're tracking it.
All right, well, as long as it's not called the New Jersey variant, well, we'll accept it for what it is. Okay, so
Rebecca,
yes.
One last thing. We spent a lot of time talking today about the vaccines and how much people are going to get infected. I put together this one slide. Let me just put it here and just close it out so I don't have to keep on bringing it every week. I had it last week too. What I'm showing you here, I'll just spend 2 minutes on this. What I'm showing you here is a comparison of Israel to the United States. Israel, again, is unique because they vaccinated so many people. You'll notice this is the total number of people infected per million. So when you compare this to the United States in our current surge, the Israel surge, despite all the people vaccinated that we talked about, is still much higher. And the variants in Israel are spreading, and the variants, you can see that there's another spike in the surge over the last week or two in Israel. And so Israel is not out of the woods yet, even with all their vaccinations that they're doing. Interestingly, though, despite all the vaccinations, I'm going to put this one behind now. We have this idea. Let me bring this to the top. Whoops. And this is the deaths per million. So one thing that's really interesting is with all of the vaccinations, remember the people who are vaccinated first in Israel were the elderly and the people with the comorbidities and those at highest risk. And so even though in the United States, we have less infections in Israel, I mean, it could be based on the amount of testing that we're doing and whatnot, but based on the general level of infections, interestingly, in Israel, they have less deaths. The infection fatality rate, or the case fatality rate in particular, appears to be less than it does in the United States. Part of this is due to the vaccination. So even though the infections are still occurring, there are less deaths, and that is really good news. But when it comes, so again, let me show this. Oops, let me bring this to the front. So this is people receiving at least one vaccine. They've had over 50%, closer to 60%, approaching 60% of the population, not quite there, but almost, having at least the first vaccine. And yet we still have the curves that I just showed you in Israel. And so this is another reason why when people talk about whether they stop wearing the masks and can they stop physically distancing now that they've been vaccinated, when you look at the real world evidence in Israel, we are not there yet. People still should be wearing the masks even after vaccinating, just for the time period. When summer comes, I think there's a strong case to be made, depending on where we're at with the variants and whatnot. But because the seasonality of the virus reduces the spread in most places generally, I think that by the time the summer hits, there's a stronger case to be made that we can take, that once people are vaccinated, we can stop wearing the masks and we can stop physically distancing and whatnot. But for the time being, when you look at the real world evidence in Israel, again, over 50%, closer to 60% have their first dose. Over a third have had 2 full doses in Israel. When you look at that, but yet you still look over here at this key graph that I just showed you, the number of people in the country still being infected is far higher than what we see in the United States. This is food for thought that we all need to be thinking about. And please, if other people you know have been vaccinated and are now promoting the idea that, oh, we don't need to wear the mask, they've been vaccinated, please share with them the ideas that I've communicated tonight, because we are not out of the woods yet. And there's still a lot of people at risk, particularly people who can't be vaccinated because they're immunocompromised or they're contraindicated. So we're not out of the woods yet. We're getting there. If you're vaccinated, this is great news. Your risk of getting severe illness or death is dramatically lower. But as a population, we need to care for other people around us. And so we're not out of the woods yet. With that, Rebecca, thanks
All
everyone.
right. So it sounds like it comes back to the immunoglobulins A. And
Yes.
it sounds like we will be awaiting details on what we can and cannot do about our IgAs. Okay. So lots more to cover next week. Thank you to everybody who has been sending in so many terrific questions. Glenn has been working hard, as you can see, in his thousands of slides, preparing answers to those questions. So next week, to give you a little preview, we'll be talking about schools. We'll be talking about the vaccine trials and how soon we can expect vaccines to be available for children. And we'll be talking more about proper ventilation and what those requirements are. And of course, more about the vaccines, more about the variants. And Glenn will continue to give us deeper dives into what we need to know so we can all go out into the world, prepare, and everybody mind your IGAs, right? So wear your masks, wash your hands, continue doing what you're doing. Have a very safe and happy week. And we look forward to being together next Sunday, same time. Be well, everybody.
Thanks, everyone. Thanks, Rebecca. Have a great week, everyone. Bye-bye.